All right. So FLE, this is a review. This is what I like about FLE and liver is you guys have had it before, right? So we're just going to bring it back, throw it into the front of your brain, pull it out of the cutaway portions. Yes. Fluid and electrolytes. Yeah. Yep. Fluid and electrolytes. Yep. That's okay. Every semester somebody asks me that. Yeah. And I always forget because we just I called it FLE for so many years. I just forget that sometimes people don't know what that means. So I'm sorry about that. Okay. So you guys can read over your class objectives. I don't need to read them to you. Okay, so let's just look at this. Let's just step back. Everybody take a deep breath. Everyone's like, oh my God, FLE, this is like post-traumatic stress, you know. Okay, let's look at every reason that you guys would have a patient that would be in a fluid volume deficit. This all makes sense. If you've got GI, they're vomiting or have diarrhea, we've pulled out suction, maybe they have bleeding or fistulas where fluid is draining somewhere else. Very common sense, right? So don't ever think that. Urinary, well, why do our patients pee fast or a lot? Well, we cause it, right? So remember when they have high blood sugars, they urinate a lot. We might give diuretics. When we talk about neuro, we'll talk about this diabetes insipidus, but it's a syndrome where the brain has been affected and they dump water. They dump a ton of urine. So diabetes insipidus. Or we have a problem with the kidneys and atubular necrosis. And we're not able to filter and reabsorb the water the way that we're supposed to. Skin, burns, right? Our cells are damaged, so they just leak everywhere. Maybe we're diaphoretic. You'd have to be really diaphoretic. But, you know, maybe you're out in the heat and people go on vacation. These are the patients that we see that come in and they were in Mexico having a great time out in the heat, drinking alcohol or not drinking enough water, and then they end up extremely dehydrated and have a fluid volume deficit. Or if our capillaries leak, right, then fluid comes out of the area in the body where we need it. So fluid volume deficit isn't just it left the body, it left the vascular space, right? So it's important that the fluid is in the vascular space because that's where we can metabolize it and use it to transfer, okay? Insensible loss, you know, it's usually if I see somebody with insensible loss, it's because they've been in the ICU for a long time. They've been on ventilation. You know, we're not keeping up with their hydration status. And then of course we get like wound healing or hemorrhage. Okay. So none of that should be a surprise to you. Okay. So you shouldn't have to like home down. And then think about physical assessment. Well, if you have somebody that's in a fluid volume deficit or overload, they can be confused. Okay. So neurologically, we might be confused. If you just go down with your head to toe and you do the oral cavity, guess what? Dry mucous membranes. Okay. Integrity, you have tented skin, porch skin turgor, pale, cool, urinary. If they're dehydrated, okay, and we're not urinating very well, what would your urine specific gravity be? High, right? Because it's super concentrated. If we're in a fluid volume excess and we're dumping water, what would your urine specific gravity be? It's gonna be low because it's gonna be closer to water, right? So urinary, we're gonna have a decreased urinary output. Cardiovascular, okay, well, you guys know what a fluid overload patient looks like, right? Distended neck veins, we might have an S3, S4. These patients are going to be just the opposite. Flat neck veins, decreased capillary refill. We might have a weight loss depending on how much they've lost. And then vital signs, if you're at a fluid volume deficit, we're tachycardic, hypotensive, right? Usually tachycardic, hypotensive. Orthostatics, most patients that are orthostatic, either drug-induced or volume loss. So if we're testing patients for orthostasis, it's because we gave a medication that causes orthostatic hypotension, or almost always it's because they have a fluid volume deficit in the vascular space. What would make somebody be hypertensive and they don't, it could be. Usually it's something that we did to them, or that they have a really sick heart. Or they have a really sick heart. Early stage heart failure sometimes. They can be a little bit, bradycarditis. It's not a cookie cutter like this is every single time. It's really related to whatever disease is going on. Yeah, but almost always, if our blood pressure is low, our heart rate goes up. Why? It's a compensatory mechanism. Your body's trying to save itself, right? Beta 1 kicks in. Okay. Okay. Oh, latency. Okay, so we already talked about urine osmosis and specific gravity. Okay. So the other thing, this makes me think of liver failure patients. You could have a fluid loss and a fluid volume excess at the same time, right? The deficit is in the vascular space, but they've got a 20-pound weight gain because all the fluid shifted from in the vascular space into the peritoneal cavity or around the lungs or third spacing in the extremities, right? So your patients could be intravascularly dry and have a fluid volume deficit, but we're actually fluid volume overload as well. And we've had a weight gain, okay? So I've actually had students write fluid volume deficit, fluid volume excess on their care plans, okay? So if you can think about that, that makes sense. Fluid fills the cavity, it compresses the soft structure, but the purpose of understanding the fluid volume deficit is that even though they have the fluid, it does not help to the metabolism or the working of the body. So they have all that fluid, but we can't do anything with it because it's in the wrong space. So that's the big thing you have to think about if you have somebody in that. And I almost always think of my liver failure patients, right? Almost always, because they use that space. They have an increased hydrostatic pressure, right? Because we have that portal vein that's trying to push the blood through the liver, but it can't. So it backs up. So I have an increased hydrostatic pressure, decreased oncotic pressure because I'm lacking my albumin. So the fluid just leaks. The fluid just leaks. Okay. So what do? Well, we're at a loss. We got to give fluid, right? So if I'm giving fluid to my patients, what kind of fluid do I give? Isotonic if we're treating a deficit in the vascular space. So if your patient is hypotensive, decreased cardiac output, their MAP is low and they're tachycardic, I don't want to give fluid that is going to go into the cell, right? I don't want to give hypotonic. I'm going to put it in the vascular space. It's going to go into the cell. That's great. I'm working on hydrating my patient, but am I fixing their cardiac output? Not yet, right? So we've got to think about why we're giving the fluid to replace volume, because you can actually, for a fluid volume deficit, you can give hypotonic, isotonic, or hypertonic fluid. Okay. If we can give oral route, that's best. We tend not to do that in the hospital though. We're like, ah! You guys that work in the ER, you can give them, nobody's running to get them a Gatorade if they come in dehydrated, right? Marathon runner comes in dehydrated. They're like, oh, no, let's just get an IV fluid, right? I was extremely dehydrated with my second pregnancy. And it was the same thing. I just couldn't keep anything down. And she's like, oh, I was like, no, just hit me with, put an IV in, hit me with a couple liters of fluid so I could be out the door. I like literally walked over from work and they're like, oh, we weren't doing fluid. I'm like, okay. So yeah, oral route if we can, enteral route, IV route though is the fastest. That is the fastest way. So if you have somebody that's hypotensive and we need to improve that cardiac output, we're not going to wait for the Gatorade to be metabolized, right? See in 2 hours. Right? We're not gonna be like, oh, we're just waiting for your body to absorb the Gatorade. See if it brings up your cardiac output, right? So, I mean, I know that sounds silly, but okay. So hypotonic solutions. So this is anything less than 0.9% normal saline. That's how I remember this. If it's 0.25, 0.33, 0.5, D5 in water, once it hits the body, because the dextrose is metabolized, is hypotonic. So these fluids are going to fill the cell. They're not going to stay in the vascular space. So if you have somebody that's dehydrated, but hemodynamically stable, they might get some of this and some isotonic fluid because we want to make sure we maintain homeostasis in the vascular space, but we're already dehydrated. This is the little old lady that fell at home, laid on the floor for 4 days, dehydrated. The cells are dry. We got to fill the cells and fill the vascular space. And they might get a combination, okay? Big thing you have to worry about though is if we're feeding the cells, can the cells burst? Can we overhydrate the cells? Absolutely, and then we have cellular damage. So we have to be super careful about that. So if you look here, you guys remember your serum osmo? What's the normal? I'm just saying this because I got in trouble for the phosphorus. Everybody was pissed about the phosphorus that I didn't review it. So let's review your labs. What's the normal serum osmo? Yes, about 270 to 300, okay? So we say the hypotonic solution has an osmolarity of less than 280 because that's what the body is. We're about 275 to 300, right? So if I want, so that's my normal serum, which means blood. My serum osmo is like 270, 275 to 300. So if I want to give a hypotonic fluid, so it'll go into the cell, I've got to give a solution that is less than that, right? Because otherwise it's the same as what the serum body is and it's going to stay in the vascular space. Does that make sense? You guys are looking at me like I'm great. So my blood, like this is my blood right here, right? Coming out of my left ventricle. The serum osmo, the blood that's in here, the range is like 270 to 300, depending on what, 275 to 300, right? So if I give replacement fluid and I want to give hypotonic fluid, what does the osmolarity of the hypotonic fluid have to be so that it doesn't stay in this vascular space but goes into the cell? It's got to be less than 280. That's what I'm saying right here. Does that make sense? Okay. Yeah, because normal saline is similar to what your body is. Does that make sense? You guys look a little bit more together now. Okay, everybody look confused for a second. Yeah, your body just metabolizes the dextrose off and then the water ships into the cell. Okay. Yep.
So why osmolarity with high particles?
Yes. Yeah. Okay. Isotonic, same osmolarity as our body fluid. So we would expect this to be very similar to that 270, 280 range to 300, right? Lactated ringers. In surgery, you guys use lactated ringers a lot? OR. Surgical ICU. You guys see SI? You say they love it in SI. They're always like lactated ringers. I don't like it. I mean, I like it, but guess what? Nothing's compatible with it. So I'm like, dang it, we need another line. Because it's so incompatible with many meds that we give. Someone was like, saline instead, but the surgeons like it. So it's the same as your body. So it's around that 270 to 300, right? Used when we need to rapidly expand intravascular volume. So this ain't going anywhere, right? I'm not pulling anything into the vascular space. I'm not pushing anything out. When I give this, it stays right in the vascular space. This is why when they come into the emergency room and they're hypotensive, you run normal saline wide open, right? You run it on pressure bags because it's going to stay in that vascular space. Okay. Lactated ringers too. For a while, do you guys remember when we had, this is why I think like devastation is so interesting. Not that I'm happy that it happens, but so when we had the hurricanes, and there was the devastation in Puerto Rico. Do you guys remember that? Like 5, 6 years, was it 5, 6 years ago? I'm bad on timelines too. We couldn't get normal saline because guess what? That's where it was made. We couldn't get the bags of normal saline. So we had our pharmacy that was mixing it herself and everybody was getting lactated ringers. So you guys know how we might give like cefazolin or you might have given Rocephin push. You guys mixed them up on clinical and you've given it over five minutes. You've mixed in like 20 milliliters. Anybody done that? A couple of people? Okay. You've mixed, and we used to always give cefazolin in like a 50 milliliter piggyback. And then guess what? That's when that changed. We said, what is the greatest concentration we can give it in? Because we don't have 50 milliliters of normal saline. So we said, okay, we can mix it in 20 milliliters and push it over 5 minutes. So that practice changed because of a hurricane. Isn't that crazy? You guys are looking at me like, just get through this damn lecture. We got to go study. So I just think that's so interesting because something like a hurricane can totally change the way we practice because we have to look at that. What do we have and what can we use and how do we prioritize that? So we were mixing our own bags. And can you imagine if you mix the bag wrong of sodium chloride, how it can affect your patient so significantly, especially if you put too much sodium in it? It can cause terrible swelling. Okay. Hypertonic, so these are anything that has more, or if you add something to normal saline. So if you add to it, it's hypertonic. So D5 normal saline, D5 lactated ringers. If you add more than 0.9% sodium chloride to your bag, so 3%, 5%, it's hypertonic. Okay, so these are used to treat fluid volume deficit where we're trying, maybe we have this in somebody that has edema everywhere and we're giving a hypertonic fluid to put the fluid back into the vascular space. This is used least commonly. You will never see 3% or 5% given on a general floor. Never. Good.
So one of the patients from Joe's on Tuesday was going to the floor. They were on 3%.
Mm-hmm.
They said they can give them on the floor, but it has to be like it can't be a bolus. It has to be like a very slow infusion.
Interesting.
Because they were arguing about that.
Yes. Do you know why? So how many, you guys have seen it, and I'll come back to you, Mike, in a second. So how many patients are, so how many patients do you have if you're on an intermediate or general floor? You're a nurse. 4, 5, 6, 7, depending, right? Depending on what floor you're on, depending on how many people you have that day. Your patient's neurological status can change almost instantly if you're giving something more than 0.9%. Okay, it causes massive fluid shifts very, very quickly. We give it all the time in the neuro ICU or SIC. I don't know if you guys use it in the ER much, but we give it all the time in the neuro places. And you have to be like, I would never run that wide open. You'd kill your patient. If that went wide open, you would kill them. So I've given it 20, 30. I've never given it more than 50 milliliters an hour. Never. If somebody, even over 40, I'm like, you sure we're gonna give it over 40? We're gonna run this drip over 40. And they're like, yeah, we're gonna get, and then you'll notice they do like Q4, Q6 sodiums, serum sodiums, we're checking sodiums. That is how critical it is. So it's very rarely used. That's probably why they were debating about it. Because especially right now with the nursing shortage.
So for the hypotonic,
Hypo. Okay.
the D5W, because we're losing the dextrose, it's isotonic or it's hypotonic in the body.
Correct.
Why wouldn't the D5NS and D5LR?
I know. Oh, D5NS.
Yeah, why wouldn't they drop down to being isotonic once they hit the bottom?
So they kind of do. They actually rapidly pull initially, and then because they have lactated ringers and normal saline, they initially pull because of the dextrose, and then once that's metabolized, it stays isotonic in the body.
I mean, I understand.
Yeah. So he's saying, why would
Like we're classifying it differently here.
So it is. So he's saying, why would one, like when the dextrose is used up, it becomes hypotonic? Well, because that fluid is really, because the underlying hypotonic solution has really never stayed really in the body or in that vascular space. If you have something like D5 lactated ringers or D5 normal saline, it instantly pulls that fluid into the vascular space, but because of the osmolarity of the fluid, it ends up staying there. It doesn't leak back out. It's even the same thing with D5.5 normal saline, or like, because of the pulling power and then the half normal saline, it rarely will just automatically leave the vascular space.
Yeah, so it's isotonic. But we're classifying it here as hypertonic.
Because initially when it hits the body, it is hypertonic. And then after the dextrose is metabolized, it's isotonic or hypertonic.
So
It's a hypertonic solution. When we give it to the patient, it's hypertonic.
D5W is
and then like
isotonic.
the water
is.
part would make it in D5W. The water part would make it hypotonic because after it's metabolized.
Correct.
Okay.
Correct. So we're,
If the hypotonic is as much with HD, they're not worried about that.
say it again.
You're saying about hypertonic, they're not usually because of the voltage and stuff that you're watching.
Yeah. Well, hypertonic, yes. 3% or 5% sodium chloride, no.
Okay.
So D5 normal saline, we give that on the floor all the time
Right.
because the pulling power isn't so great. So I want you guys to think of it this way, because students will ask me about this about all the time because they're like, have that hard. So outside of the body, D5 normal saline is hypertonic.
Mhm.
When you first give it, it is still hypertonic because it is pulling the fluid into the vascular space. But once the dextrose is metabolized, it's going to stay in the vascular space. It's not going to shift back out. So it's hypertonic. It pulls and stays. The ones that are like D5 in water,
Mhm.
once you pull that in there, water, it instantly flies right back into the cell. There's no holding power to keep it in the vascular space. D5.5, there's a little bit of holding power, so they still call that hypertonic because that holding power, once you pull it with the dextrose, but then once that dextrose is metabolized off, whatever's left is usually what the fluid will be. Yes.
So do we classify it as what it is when we first put it into the body?
Classified as I have it on the slide.
Okay.
Yeah. Yes. I will not trick you. I promise. I will not be like, you didn't listen. I said it's hypotonic after. Learn it as it is on the slide. I promise. I would not trick you.
Jill's gonna trip us.
But I just made a mental note.
So the hypertonic solution go into the vascular space, right? Like they get pulled in.
Correct.
So does that like increase the pressure in the vascular space?
Yeah.
Okay.
Yeah. It's going to pull in the vascular space. So the point of it is usually to pull edema or swelling from somewhere else into the vascular space, which is why you guys will see it in neuro ICU or trauma, because they're trying to pull the swelling from around the brain. Remember I said with your lungs, like you don't have room to expand because they're in a rib cage, your brain has no room to expand. So if you have even a minute amount of swelling, that can actually cause damage to the cerebral tissue. So we give a lot of 3 and 5% to those patients to pull that swelling out of the cells and out of that extracellular space into the vascular space and get rid of it so that we don't have so much edema in the brain. So usually we're using it not necessarily to increase the volume in the vascular space, it's to get rid of the volume where it shouldn't be in the body.
And we're gonna have them on the diuretic.
Yeah, and then we hit them with diuretics. Boom, boom, fast, fast. Or we give osmotic diuretics, which pull and diurese at the same time.
So like with people with ANSR or something like that, where they got the massive edema,
Uh-huh.
it's all in the outside itself. So that's.
Yeah. So we want to pull it. We're going to give a hypertonic fluid.
Fluid, and not, being outside or inside.
Right. You're going to pull it into the vascular space and diurese them. Otherwise, guess what this is going to do? It's going to sit and lay them in the vascular space again, for sure. Okay. So what's our desired outcomes? Well, wait, who was I? Were we on clinical? I can't remember. What was your problem initially? What's your desired outcome? Well, my map was 50. So what's my outcome? My map's going to be better. Don't write better. You guys, don't write better. Don't write normal. Don't write expected. Give me a number. So you want your map greater than 65. You want it greater than 70, which is CVP. If my CVP is down, it's 2 because I'm both. Okay, what do I want my CVP? Oh, I want it to be 5. I want it to be 7. Okay, good. So how do you know that you met your goal? Well, what is your goal? Set your goal, right? What's your outcome? We want our numbers to be what is expected for the patient, whatever that value may be. We want our serum osmo to come up, right? Our urine output with a normal urine specific gravity. What's a normal urine specific gravity? Times the quarters.
1.01.
Even you can add a nickel to the quarter. So sometimes they'll say 1.030, 1.010 to 1.025 or 1.030. Okay, that's like your normal range, right? So we were looking for that urine specific gravity. What were our problems? If we went back to the slide that you study these together, what are your clinical manifestations? Tall tinted skin turgor, dry mucous membranes, decreased urine output, elevated urine specific gravity. Well, how do I know I'm better? All those things fix themselves. Study it together. Don't make it hard, right? This is the problem. What's my outcomes? Those are better. That's no longer a problem anymore. Fix them. Let's talk about fluid volume excess. Every single one of you is taking care of somebody with fluid volume excess. Every single one of you is probably taking care of somebody in heart failure or renal failure. Everybody in the ICU is in renal failure, right? How many people take care of somebody edematous in the ICU already? You have to. They all are, right? We start shutting down the organs. So what are your problems? Well, cardiovascular heart failure, kidneys. This is not, so don't study this. You know this. Cirrhosis, liver failure. And then of course, like your cancer, thrombus. You guys have seen patients with peripheral vascular disease. How big are those legs sometimes, right? If they have a venous insufficiency, right? Steroids, right? They look like a moon face, big puffy steroids, too much sodium, okay? I love ethnic food. I love Mexican food. I love Chinese food. I love Japanese food. But a lot of times when you eat out, I eat those things out because I don't make them well at home. Guess what? My fingers look like sausages the next day, right? Because I took in a lot of salt. Why do you think when you got to eat, it doesn't matter what restaurant you go to, it doesn't matter. I say ethnic food because I love it, but when you got to eat the next day, you're swollen because they want that food to taste good and they want you to come back, right? So they're going to season it up. So you're going to try that and you're going to, oh my gosh, it's so good. And then the next day you wake up and you're like, your tongue's dry, right? Oh my gosh, I need water. Okay. So if you take in a lot of sodium, right, that can cause you to be in fluid volume excess. And then if we're not metabolizing our protein very well, or if we have a protein malnutrition, then what happens? All the fluid leaks out of the vascular space because we don't have that osmotic pressure and it leaks into the interstitial space. Okay, so assessment, physical assessment. Okay, well, you guys know this. It's the opposite of fluid volume deficit. So we're going to have a hepatic engorgement, ascites, edema, pitting edema, distended neck veins. You might hear an S3 or an S4 on your patient because we've got a fluid volume excess, right? Okay. Vital signs. CVPs, of course, is going to be up. They might have an increased cardiac output depending on what's going on with the heart. So it's going to be opposite of fluid volume deficit, right? So in fluid volume deficit, your hematocrit might be elevated. Who had a hematocrit of 18 or something this week, right? Remember we talked about that? I was like, oh my God, that's just because they're dry. Once we get that fluid back, the hematocrite's going to drop down to like maybe 15. We're gonna be like, oh my God, they're bleeding. No, we just diluted it because they were dry. So you have to look at that trend.
The hemoglobin was 18 and the hematocrit was 7.
Yeah. So here's the clue on hemoglobin hematocrit. Whatever your hemoglobin is, because it's easy to remember hemoglobin. For me anyways. You guys feel the same way? Yeah. Just take your hemoglobin, multiply it by 3, and your hematocrit's about that. So if you look at somebody, when you're in clinical next week, look at that. Look at your hemoglobin. If it's like 7.8, multiply it by 3, and your hematocrit's probably around 23, 24. So if that helps you, that helps me, because I always forget the ranges for hematocrit. For whatever reason, it doesn't stick. So in these patients, if we're in fluid volume excess, those numbers are going to be low. It's not that my patient's necessarily bleeding. It's just I have so much water on top of it. It's delusional, right? The other thing I want you to pay attention to when you're on clinical, look at the trends. So if you're looking at somebody if you're like, oh, they came in and they were dry yesterday, and we gave 3 liters of fluid, and now you see their hemoglobin hematocrit drop, guess what else is going to drop? The platelets, the WBCs, and the RBCs. You're going to see that trend go together. They will all drop because now we've diluted everything, not just the H and H, but all of your cells as well. Okay. So of course, you guys know pulmonary congestion, you might have ascites, you might see pleural effusions. And then because we have so much water, our urine specific gravity is going to be low because now we're letting go of water. We're in overload. Okay. So what's our treatment? We'll treat the underlying cause. So if you're in heart failure, we got to get the pump working again, right? And we got to take off the fluid. So we're giving loop diuretics, potassium sparing diuretics. Okay. We can give our thiazide diuretic. Every single one of these patients. Remember this, everybody's eyes and O's are so important. You better be looking at daily weights. You better be looking at eyes and O's. Okay. We better be monitoring. How many of you guys are in the ICU and they're doing hourly eyes and O's? They do them every time in SIC. I had a physician one time, he goes, oh, you're giving your patient ice chips. I said, well, yeah, there's an order to give ice chips. And he said, oh, okay, well, how are you taking credit for that volume? And I'm like, well, it's just a little 30 milliliter cup of ice chips. I'm like, I've only given them a couple. He goes, melt that down. I'm like, I don't have time for this. He made me melt down 30 milliliter ice chips and an 8-ounce cup of ice chips to see how much fluid I was actually giving my patient. He goes, now multiply that times 3 shifts. You didn't take credit for that. So anytime you have a cup of ice, this is what you'll learn in ATI, but I will also share you this because I actually clinically did it in practice after the doctor ripped my face off. Take it, it's about half. So if you have 240 of ice, it's about 120 in fluid. So if you're giving your patient 2 cups of ice, you're actually giving them 240 milliliters of fluid in that shift. So times 3 shifts, that's 750 milliliters that we've given them of fluid that we haven't taken credit for. Okay, so don't forget even something like ice chips. Same thing, desired outcomes. What was your problem initially? Did I have distended neck veins? Did I have an increased urine specific gravity? Was I hypertensive, right? Was my patient short of breath? What does a chest x-ray look like? What's my INO? Okay, what are their lung sounds, right? Okay, if they had crackles all day yesterday and we diuresed all day today, hopefully those lungs sound better tomorrow, right? That's our goal. Okay, are we good? Fluid volume excess and deficit. See, it's not that bad. You guys okay? Okay, you okay? Usually I'm like, all right, so sodium. Now let's talk about sodium. Now students get sodium and fluid volume status mixed up, okay? Write this down. Do not lump them together. They are not the same thing, okay? So if you have somebody that has a high sodium level, that doesn't mean that they're in fluid volume excess or necessarily fluid volume deficit. You have to look at your patient and see what's going on with them. Okay, so students are like, but if they have a high sodium level, that means they're holding on to so much water, they should be in fluid volume excess. Not necessarily. They could have a high sodium level because they lost all their fluid, right? So you can't put them together. So study them separate, please study them separate. Okay, so hyponatremia level below 132, okay? We usually have an excessive sodium loss, or we give medication so that some of our diuretics actually use sodium, or we took in too much water. Okay, we took in too much water and had a delusional effect. Okay, hypernatremia is exactly the opposite. 146. If I give you in a question on your exam, I'm not going to give you like 145, 146. I'm going to know it's tricky. You're going to know it's high. You're going to know it's low, right? If somebody has a sodium level of like 134 or 133, do we necessarily do aggressive treatment to replace that? No. But if they're in the 120s, are we? Yeah. because now they're could seize. Now we can have seizure activity, right? We're gonna have neuro changes. So hypernatremia, so maybe we took in too much sodium, okay? Maybe we gave too much hypertonic fluid. So maybe we gave 3%, 5% saline in the ICU. And now that's why we do Q4, Q6 hour sodium levels, right? We're checking to make sure we didn't give them too much salt, or they took in too much salt by dietary means, or we've had too much water loss, okay? So maybe we had atubular necrosis where we're just losing water. Remember we said that that was a reason that sometimes we have water loss. GI loss, maybe diabetes insipidus, that came up again. You guys are gonna need to know that. We're gonna talk about it with our brain injuries. That's where they just lose water, okay? And diabetes insipidus, so you guys remember, I don't love hormones, but in the brain, you have your pituitary gland, right, and your hypothalamus, and they secrete antidiuretic hormone, right? So you can have somebody that that too much antidiuretic hormone is released, and guess what we do? We hold on to a ton of water and end up in fluid overload. Or you can have somebody that doesn't have enough antidiuretic hormone released, and we let go of all of our water, so they dehydrate really quickly. And you'll see that in like diabetes insipidus. We'll talk about that when we talk about neuro. Or osmotic diuretics, okay? Osmotic diuretics, we actually give the patient the osmotic diuretic and it pulls out a ton of water, and then we end up with a little bit of elevated sodium level. Okay, so if we have, so I love and don't love this slide. Okay, so let me come back here and explain this to you. Because students are like, oh my gosh, this, and you lump this slide with fluid volume excess and deficit. So if you have hyponatremia, okay, if you have low sodium, are you holding on to water? Okay, are you? No. No, so you might be hypotensive, okay? So this isn't what causes hyponatremia. This is if you have hyponatremia, you're probably going to be a little bit more hyponatremic because you're not holding on to water because you don't have enough sodium. Neuro, everybody's confused. Everybody should worry about coma, whether it's high or low. If you have hyper or hypo, you have to worry about restlessness, coma, seizures. I'm not going to trick you on that. Sodium is so important. If I say potassium, what organ system do you think? If I say magnesium, what organ system do you think? If I say calcium, what organ system do you think? Good. Thank you for not saying bone. You might be the first class that has ever not said bone first. And I'm like, yes, but we're going to see a bone problem after months, right? Calcium, yeah. So I think muscle for calcium. Sodium, always think brain. Always think brain. Okay. So confusion, seizure activity, coma, restlessness, agitated, right? High or low. They might have, fluid balance. If we have a low sodium level, we're going to have a fluid balance deficit. Okay. If we have low sodium, we might have anorexia, vomiting, diarrhea, and cramping. So this low sodium causes those problems. High sodium, hypernatremia, is going to cause hypertension, right? Think about your patients in heart failure that have taken too much salt. Okay, it's Easter. They eat ham. They come in on Monday. They're in fluid volume excess, right? They had a really fun weekend over the holiday, but now they're suffering. Okay, they might be confused. We already know that. Muscle twitching seizures. They're going to have fluid excess. If they have high sodium, we're going to hold on to more fluid. Okay, so how do we treat hyponatremia? Well, we have to give fluids containing sodium. So you might give 3 or 5%. You have to really watch this. This is important. To see your hypertonic fluids, and right underneath that it says monitor for pulmonary or cerebral edema after they're given, because this causes massive fluid shifts. Okay, we can give Vaprazole. Okay, so I just said antidiuretic hormone. Okay, so this is like an oxymoron, right? Because it does the opposite. This is why I don't like hormones, because it's almost like a negative feedback loop. You guys remember that? Negative feedback loops? Okay. So if you have antidiuretic hormone, it prevents your body from letting go of water. But if you're somebody that is hyponatremic, do we want to hold on to excess water? No, because that excess water is making the sodium low. So if I block antidiuretic hormone by giving Vaprazole, then I say, antidiuretic hormone, stay home. You don't need to come out today. And it allows my body to let go of the water. Therefore, it brings up the sodium. Are we okay?
Yeah, I've been stuck in my brain since you said for a hyponatremia wouldn't be a fluid volume deficit. But I thought sometimes if you do have too much fluid, it can dilute.
So this is separate them.
That's what I'm like, I'm trying to separate them and then we're.
So if we go back,
Yeah,
if you have hyponatremia, it causes a fluid volume deficit. If you have a low sodium, it causes, so all of this is clinical major manifestations and alterations in sodium. So if you have a low sodium, it causes a fluid volume deficit because your body can't hold on to the water.
okay, see, I was looking at it like, oh, you would have a fluid volume deficit.
No.
because
So if you want
of
to talk
this
about
lot.
that, go back to the slide before we talk about hyponatremia and what causes, yeah. So that's what I'm saying. So right on this slide, if you have a low sodium, it causes a fluid volume deficit. If you have a high sodium, it causes fluid volume excess. You're welcome.
Now my brain's.
Okay. Uh-huh.
Causes deficit. And then you're saying the treatment of hyponatremia is to block the ADH, which is gonna, it's really water, it's already in a deficit. Does that make sense?
Because you know why? It's going to let go. So if the patient is hyponatremic because we have too much, that doesn't mean everybody that comes in gets that result. If you have somebody that's water intoxicated, and that's the reason that they're hyponatremic, then we've got too much water, and I've got to block antidiuretic hormones so my body can let go of the water, and the sodium will naturally come up.
So those people usually won't, like hyponatremia won't cause them to be deficit. The reason they got it was excess.
Yes, correct. Yes.
Are you saying that you would basically like have a sodium issue before you have a fluid issue? You know what I mean? It's like causing the fluid to do that.
You could, yes. Yeah.
So that's why when you're hyponatremic, we had a patient that was hyponatremic on 60%. And we did it death compression.
Mhm.
He said they
I didn't understand why they wanted to dry them out. Doctor said they wanted to make them drier. Is that why they did that?
They,
So it was 116.
and what did they give?
A salt tablet.
Oh, okay. Yes. They would give salt. If your
Right.
sodium's that low, you would give salt.
Okay.
They might give salt tablets, or we might give hypertonic fluids. So you might give 3% or 5%. So here's the thing. So look at this. If you guys look at this, if you're giving hypertonic fluid, you've got low sodium, you're giving salt back. If you're giving Vaprazole, you have too much water. So your sodium is low because you have too much water. So you have to look at the reason why your patient's hyponatremic. If your patient's hyponatremic, okay, because you took in too much water and they have all this edema, then you're going to do something to get rid of the water, not necessarily just give them sodium back. If if their sodium is low and they don't have edema, it's not water intoxication. So we don't want to block water and dehydrate them more. We want to give sodium to bring up the sodium. So you got to look at just more than one number. Does that make sense? Yes.
So when it comes to the medication, it would depend on if they would be getting
Yes.
fluid overload.
Yes.
or fluid
Yeah.
deficit.
So let me give you a practice question. Okay. You're taking care of a patient in the ICU. The patient's sodium level is 116. The nurse prepares which intervention? 3% sodium chloride, half normal saline, IV fluid continuous at 150 an hour, Vaprazole, IV drip, salt tablets, and osmotic diuretic. Or no, I'm sorry, loop diuretic. So would you give 3%? Yes. Would you give Vaprazole? Yes. It doesn't tell you if your patient's in fluid volume. All it says is your patient's sodium is 116. You have no other information. So as the nurse, is Vaprazole something you can do to raise the sodium? You better believe it. Can you give 3% raise the sodium? You better believe it. Would you give half normal saline? No, that's not going to help. Would you give a loop diuretic? No, that's going to pull off. That's going to pull off your sodium. Loop diuretics can cause you to be hyponatremic. What's the other thing I said? Salt tablets. Would you give that? Yeah. So if I don't give you any other information and that's all you have, then every intervention on this list is game for that question. Now, if I give you a question that says your patient comes in, they've had a 10-pound weight gain, they have pitting edema everywhere, what would be your priority intervention for low sodium? You might pick Vaprazole because you know that it's water intoxication.
So if you don't specify, or if it's not specified and we're not sure, it wouldn't be harmful to do.
No, because because you're not the provider that's making the choice. You're the nurse that's anticipating the interventions. So you need to know if it's an appropriate intervention or not. So if the doctor came in and your patient's sodium level was 116 and wanted to give a loop diuretic, I'd question that order all day long.
So
Proof
we
to
can go into these questions thinking like, okay, this isn't guaranteed what's gonna happen. It's
Right.
Just like, okay, these are options.
these are options.
That
Do you? Yes. Yeah.
That
And
makes
Sapropol is a type of diuretic.
No, it blocks antidiuretic hormone. So it won't actually it doesn't actually diurese and take the fluid off, but it stops the body from holding onto the water. So it allows the water to be released because it blocks blocking holding onto water. It's a negative feedback loop. This is why I don't like hormones. It's a negative feedback loop. So it blocks antidiuretic hormones. So your body's allowed to let go of the water. So it doesn't hold onto the water.
And the sodium would be diuretic.
Correct. Yes. It is. It's a treatment for cerebral edema, but we have to be super careful because that hypertonic solution causes rapid shifts that it could rapidly shift back. If it stopped too quickly, if it pulls too quickly, if you pull too much fluid off of an area too fast, guess what the body does? Tries to replace that fluid instantly. So it can cause, if you pull too fast, that's why we get it super slow. So it's almost like a rebound effect, if that makes more sense. Right, if you haven't fixed the problem, of course. It's gonna keep, we don't wait till it comes back to normal, because if it's back to normal,
I
we
mean,
fix.
once you give it, to stop it.
What? So we go back to, how do you know your patient's better? Well, my sodium, they're not batshit crazy anymore. They don't have diarrhea. They're not vomiting, right? They are alert and oriented ×3, right? They don't have any seizure activity. How do we know that we're making our patients better? Well, what was the problem initially, right? We go back to all those clinical manifestations that were the problem. So hypernatremia, we might use hypotonic solutions, right? We might have to dilute the sodium. So we might use D5 in water, right? To dilute that sodium. We might give diuretics, which actually help enhance sodium secretion, which is why we wouldn't give a loop diuretic for somebody that was hyponatremic, right? And then neurological deterioration, right? We can have massive fluid shifts. This is why we have the cerebral edema when we give the hypertonic fluid, because it shifts the fluid so quickly. Okay, calcium. We've talked so much about calcium channel blockers. You guys should be able to breeze through this really quickly. Calcium, less than 8.6. Ionized, less than 4.2. Remember,
we never talk about ionized calcium.
So ionized calcium is just a more specific evaluation of calcium, just more specific, that's all. It's just a more accurate. You guys in SIC, do they do ionized calcium? They do them all the time over there. They like it. Especially if you're messing around with, if you have any surgery on the thyroid or the hypothyroid, they will do ionized calciums a lot because they want to make sure that they keep that in check. On a standard patient on the regular floor, if your calcium's low, they usually don't do it unless they're thinking it's related to like the parathyroid or the thyroid. Yeah. Okay. So hypocalcemia, less than 8.6. Ionized calcium, less than 4.2. Maybe they had surgery on the hypoparathyroid. Okay, maybe you have acute pancreatitis. Sometimes hypomagnesium or hyperphosphatemia can contribute to calcium being low. Maybe we gave a large amount of stored blood. So stored blood has citrate in it. Okay, citrate binds to calcium so the body can't use it. So citrate binds. So if you're giving your patients a lot of blood, you better be looking at that calcium level because it's going to drop very quickly. Big deal. Okay. We just have to get calcium back.
Is that why we give calcium gluconate?
Yeah, calcium gluconate is my favorite electrolyte to give. Saves everything. When in doubt, give calcium gluconate. If you don't know, just give it. You're not going to hurt them. Okay. Hypercalcemia is about 10.2, greater than 5.2 for looking at the ionized. So why would we, so calcium is stored in the bone. This is why students are like, oh, the bone, right? But if the bone is injured, okay, or weak or prolonged immobility, the calcium leaks out of the bone into the serum. So when we talk about these electrolytes, we're talking about the electrolyte value in the blood. So it will leak out of the bone back into the blood. That's where we store it. So if you have bone metastasis, as soon as I see a high calcium, I'm like, oh, do they have cancer in the bone? It's one of the first things I think about, because I'm like, do we have cancer in the bone that's metastasized there, and now the bone is injured, and now the calcium is leaking out of the bone into the vascular space. Okay. So this is opposite hyperparathyroidism, toxicosis, or thiazide diuretics, excessive ingestion of vitamin D or calcium. So vitamin D is the analog that is essential to absorbing calcium. So if you take a lot of vitamin D, you're going to hold on to more calcium. So sometimes nobody here in Youngstown, Ohio overdoses on vitamin D. The normal range for vitamin D is 30 to 100. Even people that supplement with vitamin D usually are like 28, 30. Even my 10-year-old takes 5,000 units a day of vitamin D and she barely hits 30. She's a ginger though, so she wears like 100 degree SPF block, so she gets no sun at all. But we don't have sunny days, right? Nobody's like hanging outside today, right? Getting your vitamin D, even if it's sunny days. We don't have time. So maybe these patients took in too much vitamin D, took in too much calcium, and then maybe we just absorbed too much calcium in our renal tubules. Okay, so let's point out some important things here, right? Let's go back to our calcium, okay? And I want to show you that if you're hypocalcemic, doesn't it make sense that you might be hypotensive? Because calcium goes into the cell, activates the muscle, causes contractility. So if you have high calcium, guess what? Boom, 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 right? Because calcium's activating the cell. If you're low calcium, it's almost like giving a calcium channel blocker. The cell's not activated, the muscle's not activated, so you might be hypotensive. Think about the afterload, right? You have those arteries that have muscle in the vessel, right? High afterload. Okay, so if you have a lot of calcium or hypercalcemia, you're going to have more contraction of that blood vessel in your afterload. You're going to be a little bit more hypertensive. Okay, shortened QT. So if you have too much calcium, you're going to have a shortened QT. Why? Bing, 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 bing. Calcium's like, let's go, let's go, let's go, let's go, let's go. Come on, beat, beat, beat. Well, the faster you beat, bing, 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 guess what? That QT shortens, right? You're not like, woo! Depolarization, repolarization, depolarization, and it's like, bing, 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 right? So you're going to have a shortened QT. Okay? Cardiac dysrhythmias, right? What's the number one cardiac dysrhythmia that we have that's associated with calcium? Oh my God. 232. AFib. Right? AFib, right? What's the number one drug we give for AFib? Calcium channel blockers. We give carbazem. Right? Why? Because AFib's like, bing, 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 right? Or it's dinging all over the place. Has no rhyme or reason. We give a calcium channel blocker, like, shut that shit down. Slow it down. Right? So think about that. Don't go crazy. You already know the information. You already know it. Okay? Look at hypocalcemia, prolonged QT, long ST segment. Everything slows down. I don't have enough calcium to activate the muscle. The heart's like, bang, bang, right? If you have so much calcium that you're like rapidly going, you actually will stun the heart and they'll go into a heart block because the heart's just working too hard and too fast. Okay. Neurological, they get lethargic, they can get depressed, Don't go crazy there. Neuromuscular, super important, super important. You guys know this? I don't know why. I'm telling you, in probably 20 years of being a nurse, I've seen somebody with Chescroft's and Trousseau's twice. However, everybody likes to talk about it. So if you're hypocalcemic, you're going to have Chescroft's and Trousseau's. Okay. Let's see, bone fractures. If you're hypocalcemic, that's important. You can have pathological fractures or bone thinning if you're hypercalcemic. Kidney stones, big deal. A lot of calcium in kidney stones, a lot. Polyuria and polydipsia.
So,
Yep.
question.
Yeah.
Because I, like, in your explanation, it's like bing, 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 fast, fast, fast for hyper.
Yeah.
And hypo is slow.
Yeah.
So then why, like, when it affects the muscles, why would it be like weak for hyper? Because I would think that would be twitchy. You see what I mean? And the cramp.
Because the muscle becomes fatigued. After working so hard, that hypercalcemia, the muscle becomes weak after time.
Okay.
Yeah.
And then, but why would it be twitchy
For hypocalcemia.
I'm sorry, yeah.
It's not a, we say muscle, but it's really a neurological thing. If you put a tourniquet on somebody after so long, they will have Chescroft's and Trousseau's because of the inability to absorb and get the calcium to the nerves, to the muscles. So it has everything to do with the neuromuscular junction more than just the muscle.
Okay, so I'll just say kind of like cardiac heart. Boom, boom,
Yes,
boom,
yeah.
or cardiac muscle, boom, 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 and then like regular muscle off of it.
The number one thing we think about with calcium all day long is the heart.
Yeah.
All day long, heart and afterload. Think bone, right? Because that's where we store it. So if you need calcium, that's where it's stored. Long term, it's like chronic for patients like women that have, so that's what I really want you to think about.
Okay.
If somebody came in and they had a high calcium, I wouldn't be like, whoa, look at that muscle weakness. Whoa! It's muscle weakness. You know what I mean? I would look at more things than just that. But those cardiac things, the bone, the kidney stones, those are really important with calcium. Okay, so how do we fix hypocalcemia? We just gotta give calcium. We gotta fix the problem that made them hypocalcemic. So fix the calcium, right? So we give calcium gluconate. There you go. Here, highlight it, girl. I told you it's coming, right? Or calcium chloride sometimes, but calcium gluconate is beautiful. We love it. We give it all the time in the ICU. We give it all the time on the intermediate floor. Usually give about, you give it over an hour, usually 1 gram over an hour. Okay. Hypercalcemia, correct the underlying cause. So why do we have too much calcium? Hopefully, and you can't just fix bone metastasis, it's super easy, but if they have a bone fracture, we have to start thinking about that. We might have to give a lot of IV fluid, right? If we have high calcium, there's not really a lot that I could do to bring it down fast other than to give IV fluid and dilute it. You might have to give IV fluid to dilute it. So the calcitonin, okay, so this is my mnemonic. If you have citrate in the blood, it binds to calcium and makes it low. If you give calcitonin, it's like a citrate, it's gonna bind to the calcium and bring it low. I don't know, I just memorized that for years. So if it helps you, if you're a mnemonic person, I don't have many of them because I'm usually not, but calcitonin binds to the calcium, brings it down, just like citrate. Calcitonin is in the blood and causes the patients to be hypocalcemic. We can give sodium phos. Why does that make sense? Well, if you give phos, it drops calcium, right? They're inverse. And then your biphosphonates, those are the medications that we use for osteoporosis. So what do? It binds to the calcium in the blood and takes it into the bone. So if you have somebody that's hypercalcemic in the blood, let's give a biphosphonate, bind to it, and take it into the bone. Yeah, blood.
Calcitonin, that's calcium.
It does, but we're talking about serum.
No, I'm saying it's easier to.
Oh, for you. Okay.
It's like right in the word, calcitonin, yeah.
Yeah, tonin. It
Puts
takes
it
it
in
into
the
the bone. Takes it into the bone. It's going to bind to the calcium and get rid of it. Just like the citrate would in blood. I don't know why. It's something that mnemonic years ago. Just say it.
That's a lot of words in here.
I always said tone down.
Toned it down. Yeah, that's a good one too. You guys are mnemonics. I don't have a lot of good ones, but that might not even be a good one. I might remember. Okay, let's talk about K. Let's talk about that heart, right? All right. So low, less than 3.5, high, less than greater than 5, give or take. Why do we lose it? Well, I want you to remember that hyperkalemia, think of an acidotic state. So renal failure, they're in metabolic acidosis. Adrenal insufficiency, they're in acidotic state. If they have insulin deficiency or resistance, remember insulin and glucose takes potassium into the cell. So they might be hyperkalemic because we're not absorbing and utilizing the insulin, or we're not making it the way we should be. Rhabdo, you're in an acidotic state, your metabolic acidosis, severe burns, metabolic acidosis. Okay, and then don't forget your ACE inhibitors. Remember, you guys check that every single time we give them. Got to look at your K, got to look at your kidneys. NSAIDs can cause it, beta blockers. Why would we be low when we lose it? Okay, so if we lose our acid or we're in an alkalotic state, very often we're hypokalemic. So I vomited, right? Fluid loss, suction. Okay, maybe I excreted too much in the kidneys. Maybe we shifted the potassium into the cell. Okay, maybe we gave too much fluid. Maybe we gave potassium wasting diuretics. That's one of the #1 things we talk about on clinical. All right, their K's low. How much diuretics did we give them over the last 2 days? We didn't keep them caught up with their K. Okay, amphotericin B, you will talk about that with antimicrobials and some penicillins, but they can cause hypokalemia. So cardiovascular, most important thing with the K, right? That's what we do I think, is Texas, do they still have a death penalty? Okay, so that's what they use. They inject the patients with potassium, stops the heart. That's what they use in open heart surgery. So if you have somebody in open heart surgery and we put them on the heart-lung machine to bypass, they inject potassium that stops the heart muscle from working. Okay, so that they can work on the heart. The machine takes care of perfusion until we can get that heart back working again. Okay, so what do we see? If we have hypo, remember tall, high K, tall 10 to T wave, right? So high K, we see the tall 10 to T wave. Hypokalemia, we'll see an inverted T wave or flattened. Okay, so I think of low K, we see low changes. So low T, we'll see a U wave, we'll see a depressed ST segment. Hyperkalemia, tall 10 to T wave. Okay, they can go bradycardia, they can go into arrest because too much potassium will slow and stop the heart.
What's a U wave doing?
Pardon?
We never talked about U waves. What do they do?
It's an extra wave after the T.
Uh-huh.
So, pardon?
Yeah, but like, what's it doing?
It's just an extra flap when the heart closes. It's just the muscle's not. So QRS is contraction. T wave is relaxing.
Yep.
And after it relaxes, it like does this extra jump. So like there's irritation to the muscle.
Oh, okay, that makes sense.
Okay. So it'll always follow after the T wave. Okay. All right. So there's your flattened T wave with your U wave. There you go. There's your little extra U wave on your repolarization. Tall 10 to T wave at the bottom. Okay, so you can see your flattened ST segment there. There's some tall 10 to T waves. Okay, so how do we fix K? Well, it's low, we just give K. So slow K, KDER, IV dosing is preferred through a central line. You would never give a bolus of potassium. God forbid, please don't ever tell me that you will push it. I will not let you out of this program. If you think that you could push potassium, you will kill somebody. So we always give it. Central line, remember, if we can, okay? Because it can be irritating to the veins, to the blood vessels. It should be on a monitor. Obviously, you guys saw all the EKG changes. So we've got to put them on a monitor to make sure we keep them safe. Let's see. It's actually best to give potassium through the gut. Research shows it's better to give it through the gut. So if we can. However, if your patient's potassium level comes in and they come in at like 2.6, we're not going to be like, let's give you some oral K and see if in 4 days we can bring that baby up, right? Over 3, sure, we'll give some K. You'll see them give potassium through the gut, and then the next day it's not high enough, or later in the day it's not high enough, and then we end up giving IV potassium as well. But we'll give like 10 and 100 or 10 and 50, and then you're like, give it over an hour, and then give another 10 and 50 over an hour. So when you give it IV, if you're going to give 40 milliequivalents of potassium, you got to give it over 4 hours. If you're going to give 40 milliequivalents PO, 2 pills. Okay, so they prefer to give the gut. Watch for dysrhythmias, obviously. Monitor your potassium level, your kidney function. If your kidneys aren't working, you're not going to excrete the potassium. So if you have somebody that's in renal failure, okay, and their potassium is low from some other cause, you think we're going to give high dose potassium? Everybody say no. No. Why? If we give too much, we can't excrete it. Guess what we have to do? Now we have to correct the potassium that we gave. So you have to be super careful in potassium replacement in renal failure patients. Okay, if they're renal failure, I don't even want the PCP replacement. I'm like, where's that nephrologist? Right? Because it's so sensitive. If they're on DIG, you must assess for DIG toxicity. Okay. Hypokalemia precipitates DIG toxicity. Okay. Hyperkalemia. Well, what would cause the hyperkalemia? Are they in metabolic acidosis? Are they in renal failure? Do we give an ACE inhibitor and ARB? Do we give potassium sparing diuretics? Do we need to hold the drugs? Did we make the potassium high? We got to fix it. If not, oh my gosh, I forgot to put on the slide. Who gave the medicine with the L? The potassium. Who was it? When we were in room, not this week, the week before, when we were in room 6, remember we had to separate it by 2 hours?
Oh, yes.
And we were giving it because the potassium was up.
Yes.
Yeah.
I didn't end up giving it. Kathy gave it, but I know we waited 2 hours.
The project for today. Come up with the name of that drug because I forgot it. But I want to put it on this. Starts with the L. Yes. Yeah. What is it? Leukemia or leukemia? It sounds like leukemia. It's like low. Somebody find it because I want you guys to write it down. It's new, so it's like giving K-Xylate. and it binds to the potassium and removes it in the GI tract.
I gave him yesterday with my patient, because they pretty much sent him into AKI. He was dry, and they didn't know he was kind of dry. They gave him a loop diuretic.
Leukemia.
They gave him Lasix the day before.
Yeah.
Well, then his BUN went up to like 82.
Right.
And his creatinine was up to like 1.8, and his potassium was 5.8. So they
They had to give that. Yeah, it's a new drug. Spell it for me.
LOKEIMA.
LOKEIMA.
yes.
Right? That's it.
That's what it-
Okay. Well, right, because you guys gave it. I was like, oh my God, this is the new drug. That's just hit the market not that long ago. And it's like giving KS X-Late. It's going to bind to the potassium and bring it out through the GI tract. And I don't think it has as many side effects like the explosive diarrhea that patients are afraid of with KS. Okay, so what can we do? Well, it depends on the potassium level. How fast do we need to bring it down, right? So do we need to bring it down rapidly? Okay, do we give insulin and glucose, right? IV calcium gluconate. Why does calcium gluconate, why do we like calcium gluconate? Think about this. This is going to be full circle. This is going to take you to the whole different calcium level. Why do we like calcium gluconate? Somebody blew my mind. It's cardiac protective. Why? It's going to cause contraction. Absolutely. Because potassium is telling us stop the heart, and calcium's like, no, not today. And calcium's like, ding, ding, ding. We're giving that calcium because it's cardiac protective. It's going to force contractility. The drug of choice. Okay. However, all of these things are temporary unless we can figure out the problem of what causes it. If your patient's in renal failure, guess what? You better get them dialysis because all of these things are temporary. If we don't excrete the potassium, they're temporary. Okay. This is why we emergently put in a potassium and take them to dialysis right away. Let them go to dialysis right away. Okay, MAG. We think muscle. Okay, let's think OB. Right? Somebody comes in, preterm labor, they're having contractions. What do? Start them on a MAG drip. Why? Stuns the muscle. Somebody's in torsades de pointe, right? You guys talk about torsades a little bit with Mrs. Phillips. What's happening? The heart's like this. And how do we give it? Push 1 to 2 grams over 1 to 2 minutes. If your patient's having labor, please don't push 1 to 2 grams of magnesium over 1 to 2 minutes, right? That would not be helpful for the mom or the baby. We're going to put on that drip. If your patient needs magnesium replacement because they're just hypomagnesium, we're going to give 1 to 2 grams over 1 to 2 hours. If they're in torsades de pointe, we're going to give 1 to 2 grams over 1 to 2 minutes. So administration of electrolytes is super important. Okay, MAG less than 1.6, higher than 2.6. Okay, so let's go full circle with this. If you have hyper MAG, right? Too much MAG, what's gonna happen to your muscle? It's gonna slow down, right? Okay, we give MAG to slow the muscle. So if we already have too much MAG in the body, what happens? Hypotension, heart's not beating good. Prolonged PR, slow it down. Complete heart block, slow it down. Bradycardia, slow it down. Cardiac arrest, slow it down. Don't go crazy, you already know it. Hypomagnesium, guess what? We're gonna be fluttering all over the place. We're gonna have PVCs, right? Bing, bing, comes early, bing, bing, right? Contractions, tachycardia, VTAC, VFib, what's that ventricle doing? Bing, 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 right? Don't have enough magnesium. So low MAG, heart goes fast, high MAG, it goes slow. Okay? So remember we talked about hypomagnesium contributing to what? Remember we talked about magnesium and how it contributes to calcium? So we have hypomagnesium.
They're opposite.
Pardon?
They're opposite.
No.
Chestcalcium and trousseau. Hypomagnesium, just like hypocalcemium, chestcalcium and trousseau. So again, it's going to cause that once you're depressed in that area, it's going to cause that tremor, that neuromuscular tremor. If you see in the hypermagnesium, remember we said magnesium slows the muscle, absent of D-tendon reflexes, that's a huge deal. You'll come and see them banging on the knees and the elbows if the patient has too much MAG, because you're not going to get that reflex of the muscle. They're going to be lethargic and drowsy. So how do we treat it? So high mag, you don't see it that much, you know, unless we're giving a lot of magnesium meds. Remember, magnesium causes diarrhea. Please remember that from GI, where like we give mag, like milk of mag, it's laxative, right? You guys remember that? Okay, so if we're giving a lot of magnesium, then we would stop the magnesium if the magnesium level's high. If they're hypomagnesemia, we got to get, because the heart's not working, right? It's not working, it's not pumping good. Cardiologists hate the magnesium less than 2, even though like 1.6 or below is abnormal. Cardiologists want greater than 2. So neurological changes, dysrhythmias occur, we give mag sulfate, mag oxide, mag citrate. If you're giving mag citrate, what's your patient going to be doing? Sitting on the pot. So give it mag citrate. You could buy it over the counter at like for $1 at the dollar store. We use it. I used to use it to prep my patients for a colonoscopy. It's even more intense than milk of mag. It's like the clear bottles. They're like the clear 16 ounce bottles. Chug them. We're good for a week probably. Cleaning you out. Okay. Mag oxide. You can give oral tablets. Mag sulfate IV. Right. 1 to 2 grams over 1 to 2 minutes if they're in torsades de pointe. 1 to 2 grams over 1 to 2 hours if it's deficiency. Drip if it's over. Okay. Hypermagnesium. Okay, we got to find the reason. Look at the meds that might be containing mag, right? Like the things we just talked about. Like, are they taking over-the-counter magnesium supplements? People do that a lot for migraines. First line treatment is to give calcium gluconate. Why? Kara. It's cardiac protective. Remember I said calcium gluconate is the electrolyte of choice in the ICU? You better believe it, because if your magnesium is high, what is it doing? Stops the muscle. What does calcium do? Ding, ding, ding. You're not stopping on my watch, not today, right? It's going to force contraction of the muscle. Hypermagnesium, just like hyperkalemia, slows down that cardiac muscle. Calcium protects it from happening, okay? It doesn't lower the magnesium. Calcium gluconate does not lower the potassium. It just protects that cardiac muscle until we can fix that electrolyte ourselves. So what are we looking for? Well, of course, too much mag, everything's slow. So hypertension, bradycardia, EKG changes, change level of consciousness. Phosphorus. Okay. Below 2.5. Oh, there we go. 1.8 on the exam is not a level that we would use to wean somebody off of phosphorus or off of a med, right?
You know that now.
Will you ever forget it?
Never.
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 Never. Okay.
Yeah, right.
So when you study phosphorus, study it with calcium because they're inverse, right? So think of the things that cause hypocalcemia. They're going to cause hyperphosphatemia. If you look at the things that cause hypercalcemia, they're going to cause hypophosphatemia. Okay. You guys can read over this. Chronic kidney failure. That's what I want to point out. You will see elevated potassium and elevated phosphorus in chronic kidney failure. So what happens to your calcium in chronic kidney failure? How low can you go, right? It's going to go low. It's inverse of phosphorus. Here's the beautiful thing about dialysis. Dialysis will get rid of that potassium really fast. Dialysis does not. Know this. I promise. You need to know this. We talked about it on clinical if you had me. Phosphorus is not able to be dialyzed out. You cannot save your patient if they're hyperphosphatemia, if they're renal failure, and send them to dialysis. Somebody that I had on clinical this week, tell me what we have to do. Yes,
Phosphate binder.
we got to give a phosphate binder. And how do we give it? You're going to say, go ahead, tell me what you're going to say.
I don't know.
I'm going to wait. It's going to come back to Taylor. Or you can phone a friend.
How are we gonna give it? Like
Why do we, what do we give it? Anybody else?
through the GI tract?
Through the GI tract, when?
When they eat.
When they eat.
Oh, yeah, we gave my patient
Week one.
We were supposed to, remember we held it? And I was like, we're not, because he's not eating. So what happens is if you give a phosphate binder or a calcium supplement with a binder to it, that's what it does. Elevates the calcium level, binds to the phosphorus in the GI tract so your body doesn't absorb it. And it's excreted through the GI tract. So you have to give a phosphate binder orally when the patient eats. So we were ordered, remember you, Brady, you guys were in there, right? You guys were together. We were supposed to give phosphate binders to this patient who had an NG tube dissection with NPO. I'm like, well, the patient's not hypocalcemic. Why are we giving a phosphate binder? Phosphorus is okay. Calcium's okay. Why are we giving this? She's like, I know. So we have it. Like, why are we giving our patients a drug if we don't need to give it to them, right? So it needs to be given with the meal. Don't give it 30 minutes before. Don't give it after, right? It doesn't help the patient. It needs to be given with the dietary foods, okay? You guys can study these. Big thing I want you to know is muscle weakness. If you're hypophosphatemia, trouble getting them off the ventilator, they're weak, okay? Got to rehab those patients, rehab the lungs, okay? If we're low in phosphorus, we're probably gonna give K-phos. Who do we give K-phos on this week? Who gave K? We didn't give it on your week. Who do we give K-phos on? I swear I gave it with somebody this week. Oh, your guy.
They ordered K-phos at the end of our thing because DKA patient, his potassium and phosphorus. was low.
His
They
phosphorus
ordered it
low.
at the
You
end.
did. It was Jordan. Jordan, we gave it on 12. That's why she's probably in the background like, it was me. It was me. Yeah, we gave K-phos. So K-phos is a nice supplement for potassium and phosphorus, but it has to be given over 4 to 6 hours. It's like a 500 milliliter bag. You cannot give phosphorus IV fast, just like you can't give potassium IV fast. So we give it sodium phos. Most often we use potassium phosphorus or K-phos, slowly over 4 to 6 hours. We can give Nutrifos PO if we need to give Nutrifos. Okay, assess for muscle weakness, especially the ventilated treatment. You guys probably think that, I think that's important, right?
You think?
I think hyperphosphatemia, okay, too much phosphorus. So these are our binders, right? Renagel, phos low, it's gonna bring the phosphorus down. Renagel, take with meals, super important. Okay, we can give sodium chloride to promote renal excretion if the kidneys work. Please do not take that answer if the kidneys are in complete renal failure. It doesn't help them if they're not making urine, right? And then monitor your levels. Okay, metabolic acidosis. Okay, so you guys know your gases, right? So if you're in metabolic acidosis, we're thinking acidotic state, high K, renal failure. Okay. If we're looking at metabolic acidosis, we need to look at the venous CO2. From here on out, if anybody writes that the venous CO2 is related to respiratory, I'm going to rip up your care plan. I'm literally going to print it out and rip it up and say, you get no credit. So venous CO2 is a indirect measurement of the metabolism of the body. It's looking at what the kidneys are doing. It's looking at your bicarb, and that bicarb's a waste, right? So we're looking at that waste and that bicarb, that acid-base balance, and you're looking at the venous CO2 to look to see if you're acidotic or alkaline, okay? The measurement's the same, 22 to 26, just like arterial, but when we're looking at arterial gases, we're looking to see if it's metabolic or acidosis, if it's respiratory or renal. When we're looking at venous CO2, we are looking at the metabolic demands of the body, okay? Now, could your patient be in respiratory acidosis and your venous CO2 be up, which would mean that you're alkalotic because it's compensating for the respiratory acidosis. But the venous CO2 is up because it's compensating, not because the patient's in respiratory acidosis. Your patient can be in respiratory acidosis and your venous CO2 can be down because it's not helping. So just because the venous CO2 is up, it doesn't mean the patient's, or just because your patient's in respiratory acidosis, that doesn't mean the venous CO2 has to be up. But if it is, it's because it's compensating. It's because the kidneys are helping, not because your lungs are bad. So it's never an indicated measurement because your lungs are bad. Anion gap, know this. Know your anion gap. Anion gap greater than 16, metabolic acidosis. So you have somebody that comes in with DKA and they put them on an insulin drip. That's all they talk about is the gap because they're in metabolic acidosis. And are we closing the gap? Because as soon as we close the gap, we can get them off the insulin drip. Okay, they're in an acidotic state and we work on making them a little bit more alkalotic and get them out of metabolic acidosis, right? Yes, know how to calculate it. Know how to calculate it, know your anion gap. All right, so if we're going to treat somebody for metabolic acidosis, obviously we have to treat the nausea and vomiting, treat the DKA. You might give bicarb Sometimes bicarb is controversial, but in severe cases, you guys ever hear in a code, give some bicarb? Because we know that if they're teeming, they're acidotic, right? We don't have gas exchange, the kidneys have shut down, we gotta give some bicarb. Maybe we dialyze them, right? They're acidotic, we probably have a high K. Kidneys are failing, right? Respiratory compensatory with increased aspirations or Kussmaul's. So you might see somebody that's in metabolic acidosis, and guess how they're breathing? What are you gonna do? Nothing. Let them breathe like that. They're compensating. Don't give them a bag, right? They're like, oh, breathe in this bag. No, they're trying to blow off that acid, right? They're deep breathing because they're trying to compensate for themselves. Alkalosis, so your venous CO2 is greater than 29. So why would you be in metabolic alkalosis? Well, we got rid of our acid, or we bound to it. So you maybe gave Tums, you gave some kind of alkalizing agent, and it bound, and it was binding to the acid. So maybe a lot of Tums, GI meds, right? Bovo, I told you I was gonna call on you when we came here. So don't do it. All right, I'm gonna use your situation. So the first thing, what do you guys all ask us the first thing I see? Do we have to look up all these meds? Everybody in my clinical visit, do we have to look up all of them? I'm like, yeah. She's like, even all this GI stuff that we learned, and I was like, yeah. So you look at the patient's gases and the patient's in metabolic alkalosis, and I said, why do you think you're metabolic alkalosis? So after we have our dialogue, and she's like, all right, shut up and just tell me, right? Because we're like talking this out. I said, oh, what's your patient been getting? Tums, Pepto-Bismol, proton pump inhibitors. We made the patient metabolically alkalosis. She's like, all right, I'll look them all up. I'm like, it's important. The patient, because of all the GI stuff we gave them, ended up in metabolic alkalosis. We made them alkalotic, and they were not terribly, but pretty alkalotic, right? So we can make our patients alkalotic just like we can make them acidotic. Okay, so stop the treatment, decrease the bicarb, treat the hypokalemia. Remember, acidosis high K, alkalosis low K. All right, at 11, we're going to do our quick interactive case study for liver. Okay, take a break. And then we're going to go over the case study at the end, like you guys talked about too. Okay, hold on one sec.